What should a myeloma patient consider when choosing a treatment option?
Due to the breadth of new myeloma therapies that have come out in the last decade or so, the mode of administration is quite different amongst them. So we have several oral options, we have several infusional options, we have subcutaneous options, and then there's various combinations of all these medications. So when we're thinking about optimal therapy from a patient perspective, I do think quality of life considerations need to come into play. That could simply be travel related. A lot of patients travel from far away to get some of these infusions, and I think if a potential oral therapy can get them the same benefit with, let's say, a different toxicity profile, that may be preferred as long as the patient and physician are on the same page when it comes to the likelihood of benefit they may receive from an all oral therapy, for example, versus an infusional therapy. I also think toxicity from prior therapy is an important consideration from a patient perspective. What I see not uncommonly is patients that have had peripheral neuropathy from prior bortezomib exposure. A lot of times, it's become a part of their lives. They've spent the last several years managing that, whether that's with medications or other methods. And at that time, I feel like sometimes they kind of downplay the impact that might be having on their quality of life. So it's important for the patient to communicate with the physician to let us know what they feel day to day. And because we do have many options now, we could potentially limit or progress further symptoms from developing as they may impact quality of life going forward.
Why should an individual get a second opinion before choosing a treatment option?
I think as myeloma therapy becomes more complex, I think it is important to get different opinions when you're at a point of making decisions about what the next line of therapy might be. I truly believe, again, that myeloma therapy must be very individualized. And for that, there may be difference in opinions amongst different people about what the next best thing might be for an individual. That doesn't make one option right and the other one wrong. I do think, however, it is important to get all the information and get thoughts from people about why those rational combinations are being recommended for an individual, even if they're different. So it's important from a patient's perspective to understand the thought process that goes in when choosing lines of therapy, because we do, think of myeloma as a marathon. So if we are potentially recommending a very active combination, let's say in the first relapse, we also think about what might be available for the patient in the future if they relapse on this recommended regimen. So it's important to think not just in the moment, but also several steps ahead to make sure that we are not potentially eliminating certain options for patients that may benefit them, let's say, at a later time. So I tell people they should think about getting a second opinion every time they feel like they, want to get more information, and that by no means is a negative factor on their local physician or their primary oncologist. It really just comes down to your own peace of mind and making sure you fully understand all the medications that we have available and why we might be recommending a particular combination or not. And the second thing I will just say is anytime, consideration is being given for a particular clinical trial, let's say that's not available at your local facility, I think that's another time to explore at major academic centers to see what is available at that moment for an individual, which may be different because it is in clinical trial format than what might be recommended at the primary oncology with the primary oncology team.
How do you make a treatment decision with either relapsed or refractory myeloma?
That's a very common question, that one that we have to deal with in clinic, unfortunately, quite frequently. A patient that comes back has relapse or refractory disease, and you have to make the choice of the next line of therapy. It's a process that has to do as much with the art as it has to do with science, because even though there's abundant data on how this regimen perform or that regimen perform, there's really not a roadmap for a given patient. So like my colleagues, we try to look at a few things. First and foremost, efficacy. I mean, patients, particularly patients with relapsed disease, they often they want to start a new therapy, they want a therapy to work, and oftentimes they need a therapy to work fast because their relapse has come with threats to their kidney function, with anemia, with fatigue, or with pain. So activity certainly is first in rank. But the other things that are important is how frail is that patient, how important is convenience for that patient. If you have a younger patient with not a lot of comorbidities, can have no problems commuting back and forth to the clinic, you can really pick your triplet combination that you think has the greatest activity and employ on that patient, as opposed to a frail patient that come on a wheelchair, is in the 80s, and lives 2 hours away, where you're going to lean more towards oral drugs or infusions that are not frequent. And another factor that is just as important is what that patient has been treated with in the past, and how has the patient responded, and how has the patient tolerated. So a patient who has substantial neuropathy from prior therapies, you're not going to choose another agent or combination that has a high rate of neuropathy. Or a patient who has, significant low platelets or low neutrophils, you're not going to choose an agent or a combination that has a high risk of neutropenia, of reducing the white blood cell count, or reducing the platelets. And a little bit in line with what we discussed about refractoriness or relapse, you tend to redeploy drugs that the patient was exposed to before, as long as the patient responded and tolerated, but you are unlikely to reintroduce a drug that the patient's disease was refractory to in the past. We just assume that once the disease becomes refractory to the agent, although this might not be always true, it's safer to go on a different direction and use another agent on the same class or a different class of agents altogether.
Your information is scattered across multiple facilities. HealthTree gives you a single place to put all of your myeloma records and create a summary of your disease to easily get a second opinion from a myeloma specialist. This page was designed with help from top myeloma specialists and has everything a myeloma specialist needs to help you make an informed treatment decision. So if you haven't already, join HealthTree today.